We are live.
Good evening, everyone. Welcome to iFocus Online, Lecture 121 and the Glaucoma Session 25. Now that we have covered the basics of glaucoma, we move on to the management aspect of glaucoma. And today we have with us Dr. Andrew Braganza from CMC Vellore, who will be talking on principles of medical therapy of glaucoma, concept of target pressure, role of DVT, and the concept of neuroprotection. And I request Vanita ma'am to please introduce her.
Thank you very much, as usual, Rolika, and it is always my pleasure to introduce our guest speakers. We welcome, Team CFS welcomes Dr. Andrew Braganza today, who is very closely associated with Christian Medical College, Vellore, where he did his MBBS, and then he went to AIMS, worked there for a while, and then completed his post-graduation in ophthalmology at did his post-graduation in Chandigarh, and he then subsequently joined the Department of Ophthalmology at CMC Vellore as faculty and as continues as professor now and head of glaucoma services. He is not just interested in glaucoma. His other areas of interest are neuro-ophthalmology, strabismus, and oculoplasty. He is a postgraduate teacher and has been doing so for the past 30 years, and is also an examiner for several universities and the National Board of Examinations as well. So really the hot seaters would have benefited very much by asking and interacting with him today. So we request them to join as soon as possible, because they have an examiner here who can answer their queries. With these words, Dr. Andrew Braganza, I request you to take over and give us your lecture on principles of medical management in glaucoma, concepts of target IOP, DVT, as well as neuroprotection.
Thank you, Dr. Vanita. And let me get my slides on. Okay. Are you able to see the slides?
Yes. Yeah.
Okay.
Right. Yeah.
Okay.
Great.
So, yeah. So I'll start without any further ado about the principles of medical management. And really, medical management is all about intraocular pressure. So I'd first have to have a few words about intraocular pressure and glaucoma, because right now we are treating only intraocular pressure to treat glaucoma. So if you look at primary open angle glaucoma and intraocular pressure, there's a strong association, there's a causal association. And that's because we all know, and there's a lot of evidence to prove, that higher IOPs lead to disc damage. The higher the IOP, the greater the progression. You control the IOP, you can retard progression. If there's asymmetric IOP, then there's more damage in the eye with the higher intraocular pressure. Again, we are a little unsure about intraocular pressure because there's really no safe level to say that, okay, at this level of intraocular pressure, you're safe, you won't have further glaucomatous damage. There's an enormous amount of individual variation of the eye in response to raised intraocular pressure. And then the obvious question, where does the so-called normal tension glaucoma fit in? And other questions like, how does increased IOP damage the target tissue? I'm not going to go into details about all these things because we are dealing with the principles of medical management, but I just want to emphasize that intraocular pressure, which is what we are trying to control when we medically manage a glaucoma patient, is a subject that is really not greatly understood. We know a lot about it, but there's a lot more to know. The big question when we are treating glaucoma is, does reducing intraocular pressure in glaucoma actually work in treating the disease? And to answer this question, we need 3 items of information. First, we need to know the natural history of the disease. Then we need to have good definitions of treatment aims when we are aiming at treating intraocular pressure. And finally, we have to have evidence from randomized controlled trials using these treatment aims and comparing it to the natural history to say whether or not intraocular pressure actually works in treating glaucoma. So the first item, the natural history. And I would refer you to this article, which was published some time ago in 2002, where they studied the progression of visual field loss in untreated glaucomas in St. Lucia in West Indies. Now, what they did was, on the basis of a population-based survey, they identified 205 patients with primary open-angle glaucoma, and they followed these up for 10 years without treatment, just to see what happens when you have glaucoma, which you've diagnosed but don't treat. Between half to 3/4 of these patients showed progression. The cumulative risk of at least one eye going blind in 10 years was about 16%. And with these kind of figures, it's very obvious that this study cannot ethically be repeated. So we know the answer to that. We know what the natural history is. So what's the aim of treatment? Well, we are not simply treating the intraocular pressure, although that is what we are, it's a short-term goal. The aim really is to make sure that the patient's vision lasts out his lifetime. And for this, quality of vision and quality of life are also important. And here's where we come to the concept of target pressure. Now we have to try and identify in the individual patient the intraocular pressure below which progressive field loss is unlikely to affect the patient's quality of vision during his lifetime. Now, this is one definition. Okay. Another would be as that pressure at which the rate of ganglion cell loss equals the age-related rate. That is, you've eliminated all extraneous factors, and now the patient is losing ganglion cells at the same rate as a patient without glaucoma. So these are all different ways of defining target pressure, not necessarily mutually exclusive. Another definition would be the level of intraocular pressure at which no further clinically evident damage occurs. And this is really what we define for ourselves when we are treating glaucoma as clinicians. We look at the fields, we look at the discs, and we may record them with all sorts of devices. And we try to ensure that we are not able to clinically detect any further deterioration. And we say, okay, so this pressure seems to be working for this patient. If you want to be a little more technical, you can say that the intraocular pressure at which the sum of the health-related quality of life from not having field effects and the health-related quality of life from not having side effects of the treatment is maximized. So here you're also taking into account the fact that your treatment may not be quite comfortable for the patient. The patient may be distressed by the number of times he has to put drops. Patient may be distressed by the side effects of the drops, by the stinging, by whatever it is, by systemic side effects. And this also affects the patient's quality of life. And therefore, what you want to do is to make sure that you balance the quality of life that is related to glaucoma and related to the treatment of glaucoma. And now the third part of the thing was the ICTs. And we had the early ICTs were very definitive, and they were numerous, a complete alphabet soup of randomized clinical trials. And we had some of these listed here. And these were really very key trials in us defining what our objectives, aims, methodology in treating glaucoma is. And what the RCTs actually showed, the first question that we wanted answered, does IOP control work? Yes, it does work. Progression of field effects was stopped or retarded by appropriate treatment. And we documented this in RCTs. Blindness was prevented. And in ocular hypertension, conversion to glaucoma was probably halved by giving hypotensive medication. There is always a flip side, there's always the other side. And we found in the RCTs, reported as well, that treatment is associated with complications that reduce quality of vision and reduce quality of life. And all these RCTs, while giving us a lot of very important information, did not address the cost-benefit ratio of treatment. So if you look at a few points to consider in these older RCTs, that the OATS trial, for instance, many of the converters may have been undetected POAG because the newer tests of morphology were not used. And CCT was very predominantly mentioned in this study, but it is not clear whether the CCT just reflects an inaccuracy in the measurement of intraocular pressure, or does it reflect an independent risk factor? And we are still wondering about that. And although the risk of open-angle glaucoma is halved, it is still only 5% above baseline. What's the significance of this? And similarly, there are points to consider in all the trials. In the NTG trial, there were so many confounders. It was more common in females, migraine, other symptoms of vascular insufficiency. There was no dosimetry in the IOP control, which was achieved. An arbitrary 30% was just defined. And it really was very difficult to try and apply that study to a real life clinical situation. And similarly with the initial glaucoma treatment study, where again, we had quite a few flaws. So leave aside the studies, but what are we actually treating? We are, on the basis of the studies, we treat open angle glaucoma once we diagnose it, NTG or even ocular hypertension, on the perceived risk, which has been shown by the RCTs and by the natural history, that no treatment of this glaucoma is going to decrease the quality of vision. And we are probably justified in treating on that risk. And the risk is based on statistical data from published studies. And for the individual patient, this may apply, it should probably apply, but we are not sure. It may not actually be real for that particular patient, because that, maybe the patient belongs to a subset which was not studied or which behaves differently from the data that we got from the studies. If we have to treat based on fact, based on what actually we know about the individual patient who's sitting in front of us, then we need to have a lot of longitudinal data on that patient to establish progression and the rate of progression and how it affects the quality of vision and quality of life. And again, these are very subjective things because all this depends on what the patient's visual demands and what the patient's, what the patient's expectations from life are. And accordingly, he would be able to judge the effect that this disease is having on his quality of vision and quality of life. The identification of target pressure below which progression will not occur then is based on this data that we collect from the individual patient. Once we've decided this, and then we say, okay, we want this target pressure, we are faced with another couple of questions. In any individual patient, will treatment reducing intraocular pressure inevitably be of benefit? So does treatment always benefit the patient? Is it better to reduce the intraocular pressure as much as possible? Or is it that we just want to reduce it a bit? So again, a couple of important questions. And for this, we need to really know what we mean by benefit. And if you use the NNT, the number needed to treat, we can take the example of NTG. If we want to preserve quality of vision in one patient, we need to treat about 17 patients. And to achieve the kind of pressure that we want to achieve in 17 patients, at least half of them will require trabeculectomy. And some of these will develop cataract because of the trabeculectomy, because of the surgical intervention. So we are actually paying a cost for our intervention just for the sake of actually benefiting one patient. If you want to consider the actual calculation of NNT, let's take the example of a study population where the risk of the disease is 20%. Say that we reduce this risk to 10%. The absolute risk reduction is 20 minus 10 is 10%. The relative risk reduction is the absolute risk reduction expressed as a percentage of the original risk, which is about 50%. So yes, we can reduce the relative risk by 50% if we treat. This relative risk, however, this 50% would be the same whether we reduce the risk from 100% to 50% or from 1% to 0.5%. The relative risk reduction is still 50%. And this becomes meaningless in the latter case, but is of enormous meaning in the first case. NNT, when you calculate it, uses absolute risk reduction, not relative risk reduction. It's just 1 upon absolute risk reduction. So in the 10% case, it is 1 upon 10%, which is 10, which means you need to treat 10 patients before we are sure that we will actually be benefiting 1. In the case of 50% absolute risk reduction, if the NNT, if the relative risk reduction is actually 50%, then the NNT would be just 2, and that's significant. In the OATS trial, okay, the risk of developing glaucoma was reduced from 9.5 to 4.4%, and this was reported as a relative risk reduction of 50. But the absolute risk reduction is only 5%, and therefore the NNT is 20. So you have to treat 20 patients with ocular hypertension before you are actually sure of benefiting 1. And therefore, you're exposing all 20 to all the risks and side effects of medications and whatever other interventions you choose in achieving your target pressure. And you're only going to benefit 1 of these. So you need to always look or roughly calculate the NNT in all situations clinically. Now, here's a suggested approach to ocular hypertension, and this really hasn't changed very much. So I'm sticking with the 2003 table, which was proposed by Hitchings and Grieve. And here they advocate treating patients whose mean IOP is above 30 or peak IOP above 35, and you aim for a 30% reduction based on the data that they had at the moment, and the rest you follow up. And the the flow chart is fairly obvious. If you find that things are getting worse, then you shift more and more towards treatment. What is important is really what I have put as ROP here, which is rate of progression. They emphasized that we are aiming to give this patient comfortable vision throughout his life. So we look at the rate of progression and not just the fact of progression, of whether progression is there or not. If the rate of progression is such that it's not going to significantly affect the patient's visual function throughout his life expectancy, then we probably should not be doing anything. And similarly, we have another flow chart for primary open-angle glaucoma. So they defined it as, early or moderate and advanced glaucoma. And when you have advanced field defects, you treat vigorously and you try and reduce the intraocular pressure by more than 30%. And you do whatever it takes to reduce that intraocular pressure. If medical treatment doesn't work, then you need to go on to surgery or laser or whatever is your established practice pattern. An important fact that emerged from the RCTs and which was used by most glaucoma specialists at the time and even now is that 25% reduction of intraocular pressure reduces progression quite significantly, and a 35% reduction reduces the risk to almost 0. Now, this may or may not be true. We in fact, many specialists advocate trying to reduce the intraocular pressure by 50% or more, particularly in advanced primary open-angle glaucoma. But these are the facts that we were presented with in the RCTs at that time. And this is probably the protocol that most people still follow today. And now, since we are dealing with intraocular pressure, we come to this very vexing subject of the DVT, the diurnal variation of tension. We do know that intraocular pressure fluctuates during the day. We know that the fluctuation is higher in primary open-angle glaucoma patients. We do know that medical treatment does not eliminate this fluctuation. The rise and fall of intraocular pressure still persists throughout the day, even though medical treatment may bring down the overall mean pressure. So the question is, do we need a DVT? Now, a significant percentage of primary open-angle glaucoma has IOP in the normal range at first presentation. It's considered to be maybe about 30 to 40% of POAGs in a single intraocular pressure reading would demonstrate a normal pressure. And therefore, for diagnosis, it's probably needed to do a diurnal variation. However, the so-called office DVT, which is not a complete diurnal variation, but only pressures measured 2 or 3 times during the office hours, usually picks up a raised intraocular pressure. And therefore, a DVT is probably not necessary for diagnosing primary open-angle glaucoma. So do we need it for treatment? Well, identifying the pattern of intraocular pressure fluctuation can be useful and can be helpful in the timing of medication, advising the patient when to instill the medication so that you try and catch the peak of the intraocular pressure at the peak time of action of the instilled drug. And this also can be used to explain why a good intraocular pressure control, target pressure achieved, etc., but still we have progression, the fields are getting worse, the disc is looking worse, and this glaucoma is just not coming under control. A diurnal variation may show you that actually the intraocular pressure may be fluctuating beyond the limit of the target pressure that you have set, and this may be the reason why progression is going on. There is very strong evidence for association of progression with increased fluctuation in both normal tension glaucoma and primary open-angle glaucoma. And this is not just the short-term fluctuation which is measured by the diurnal variation, but also long-term fluctuations that over time, the mean intraocular pressure measured by successive DVTs, longitudinally in time, that the mean intraocular pressure may fluctuate, and this also may affect progression and rate of progression. So another, well, I just put that down there as a matter of curiosity. Posture and nocturnal supine intraocular pressure is also been queried as a reason for progression in glaucomas where otherwise the intraocular pressure seems controlled. And is it worthwhile measuring nocturnal supine IOP? Up to now, really probably not necessary, but we don't have very strong or hard evidence. Now, again, in the question of DVT, when you have, normal tension glaucoma and primary open-angle glaucoma, is it likely that some normal tension glaucomas would be redefined as primary open-angle glaucomas if you did a full DVT on these patients? And the answer is no. And this is a study which we have done here. The data is as yet unpublished, but I'm pretty satisfied that we were not able to, in even a single NTG patient, establish that the fluctuation of intraocular pressure untreated was such that it exceeded the definition of NTG and therefore could be reclassified as primary open-angle glaucoma. This question may seem, just a matter of semantics, but actually it's quite important because There are significantly different mechanisms of disc damage and glaucomatous progression in NTG and in POAG, and it's probably worthwhile for us to be able to make out the difference between the two entities. Would we redefine target intraocular pressure based on a DVT? Possibly yes. And is a DVT required routinely in management? I have purposely left this question unanswered because my perception of things is that we are treating glaucoma entirely on the basis of statistics. Our diagnostic tests are heavily statistically oriented. Our evidence for treatment and for situations in which we have to do this or that or whatever is all very statistical. And statistics only function well when you have a large amount of data. And a DVT does contribute a large amount of data. It gives you a little more data to play around with, and therefore the validity of your statistical decisions might be better if you had more data to play around with. In practical terms, however, a DVT is very awkward to manage. It's extremely labor intensive, and we really have no clear picture about how it actually contributes towards management. So getting back to the primary topic of medical management, now I'm not going to go into all the classes and numbers of drugs that are available. This is easy for anyone to read up from any of the textbooks, but I'm just going to go to the principles of how you would try to prescribe drugs. And these are some of the basic principles that you would give the minimum number possible. If in doubt about the efficacy of a particular drug in a particular patient, do a therapeutic trial. Try out the patient on that drug, establish if that drug has a particular effect on that patient's eye, and then only prescribe it for regular use. You'd be surprised at the number of patients who have cardiac, respiratory, renal problems, all of which can be aggravated by glaucoma medications, particularly the beta blockers. And it's extremely important to be able to identify problems when they arise, because the patient may not even associate his glaucoma treatment with those problems. And it's up to you to be aware of the problems and ask about them. And then, of course, you monitor for the efficacy. So what are the drugs? And in decreasing order of efficacy, we have the hypotensive lipids and the beta blockers. We have recently added ROCK inhibitors to our armamentarium. The exact position in this whole chain of, of therapies available is not terribly clear, but they definitely have a role. It's a new class of drug and very exciting. And then you have brimonidine, topical carbonic anhydrase inhibitors, and Pilo. So combinations often have to be used. Sometimes a single drug is not enough. And most of the combinations contain a beta blocker. So you can see the first 4 or 5 combinations I've listed all have beta blockers in them. There is, when there's a contraindication to beta blockers, at the same time, you're not achieving your target pressure and you need a combination. Well, brimonidine with a carbonic anhydrase inhibitor is also a rational combination. And the new ROCK inhibitors, well, it's classically been combined with xalatan, with latanoprost, and it could be combined with beta blockers and possibly with other classes of medications, and all this remains to be found out. So, since compliance and adherence with medical treatment is very poor, even in highly educated patients in developed countries, etc., it's basically human nature. It's the same all around the world. So it's less than 70% all around the world. And therefore, it's up to us to try and make things as easy for the patient to comply with as possible. So you try and choose the drug with the lowest frequency of applications. And that's obviously the prostaglandins and now the ROCK inhibitors. You choose the minimum number of drugs so that the patient is not confused. Remember, many of these patients are elderly patients and tend to get confused about which drop to put when and things like that. So you choose the minimum possible number, and this is where combination preparations are useful. And of course, in developed nations, this may not be so important, but in developing countries, it is definitely very important. We need to know the economic factor as far as medication is concerned. So the logical choices would be a prostaglandin as the first line if the patient can afford it, otherwise a beta blocker. And if there's any contraindication to either of the above two, a topical carbonic anhydrase inhibitor or brimonidine could be used. So you aim for a target IOP, and then you follow up with intraocular pressure, disc and fields to confirm that there is no progression. So you have to assess that your treatment is actually working, that it's actually, first of all, reducing the intraocular pressure, and secondly, that the reduced intraocular pressure is low enough to prevent any progression of the glaucoma. And again, remember these facts: 35% in reduction in intraocular pressure, very low chance of progression, absolute level of intraocular pressure in primary open-angle glaucoma less than 18 millimeters of mercury, again, very low chance of progression. A word about treating the patient and not the disease. Now, this is a symbolic representation of a patient's life. And if you look at this green dotted line, that is a patient without glaucoma whose visual function slowly deteriorates over time. And this is where you start with 0 years and you end with death. And this, the x-axis is time. So over time, any normal person experiences a slow reduction in visual function. Now, a mild glaucoma might show this purple line, okay? And if it worsens somewhere, then the slope of the line gets more and more steep and going down towards this black dotted line, which is severe functional impairment. Basically, you don't want this patient's visual acuity or visual function to cross this black line. The patient should maintain his visual function above this black line until he reaches his normal lifespan. So you want the patient's vision to last him until his death. And this can vary depending on whether the patient has other systemic problems. Life expectancy is very different in different places, in different conditions, in different races, with different socioeconomic status, things like that. But basically, whatever the patient's life expectancy, our aim is to give that person adequate, comfortable vision throughout that life. So what's next? Neuroprotection. And this is an extremely interesting topic, and a definition, a sort of older definition, is any treatment that targets prevention of progression of glaucoma, regardless of whether or not it controls the IOP, can be termed neuroprotection, because it was assumed that if you prevent progression of glaucoma, of field effects, of nerve damage, without actually controlling the IOP, you must be doing something to actually protect the nerve. And this concept has been taken a lot further since those early days. First of all, the mechanisms of damage to the nerves are many. The main one seems to be excitotoxicity, which is glutamate mediated and NMDA dependent. And memantine was initially used to try and block this, but memantine does not work in glaucoma, although it has spectacular effects in other neurodegenerative conditions. So that was eliminated, but excitotoxicity as a mechanism of damage definitely exists. Then you have the lack of neurotrophins, which happens with age, that as you lose more axons and ganglion cells, the amount of neurotrophins which the nerves need may actually be less. And if you could supply these neurotrophins, then you prevent apoptosis, which is the programmed cell death that occurs in neurons. you can prevent apoptosis if you have adequate neurotrophin levels. And this again has been shown. Then, of course, you have this very toxic molecule called nitric oxide, and I'm sure many of you are aware of all the things that it does. It's one of the essentially one of the free radicals that cause a lot of cellular damage all over the body, and the nervous system is certainly no exception to that. It's very vulnerable to that. So if you can protect the nervous system, and the eye is part of the central nervous system, if you can protect the nervous system from nitric oxide effects, then you essentially are prolonging the life of that nerve tissue. Calcium excess has definitely been shown, neuronal calcium excess has definitely been shown to be associated with nerve damage, and calcium channel blockers have been shown to be effective in preventing glaucoma progression as well as preventing nerve damage. And you have to try and arrest free radical formation, whatever the cause. So as I said, memantine, as I mentioned before, is ineffective. Surprisingly, brimonidine is one of the most effective neuroprotective agents that we know. And if you can achieve adequate concentrations of brimonidine in the vitreous so that it's working on the nerve, then you are achieving neuroprotection, even if the brimonidine may not control the intraocular pressure that well. So the Logan study did show that, but what it also showed was that there's an enormous number of dropouts when patients are on brimonidine because of severe allergic side effects and difficulty in tolerating the medication. So about maybe around 11% of patients on brimonidine experience these kind of side effects, bad enough that they want to discontinue the medication. So I mentioned calcium channel blockers. Ginkgo biloba, a natural substance, a herbal preparation, has been tried. And while initially it sounded very promising, the studies from China, where this concept originated, have shown that it is equivocal at best in its results. So, and then you have a whole lot of other things which have been tried. Citicoline is one of the promising agents, nicotinamide, antioxidants, etc., etc. But to my mind, what is more exciting is the gene and stem cell therapy that is being developed now. This may actually go beyond neuroprotection to neuroregeneration. That is, nerve fibers, ganglion cells which have been lost may be induced to regenerate and reform their synapses, re-establish their function, and reverse some field effects. And there has been some evidence and some purely anecdotal evidence so far, but this is possible. However, it's far too early to comment yet. And before I end, I think that we need, before we completely abandon our standard pressure lowering topical medications, I think we need to look again at the absolute revolution that's going on in drug delivery systems. And when you have a drug delivery system which obviates the necessity of having to put a drop every day or even every once a month or even maybe once in 6 months, then you are revolutionizing medical treatment. And there already exists injectable implantable devices which will slowly release minuscule quantities of a drug intraocularly, because you only need minuscule quantities when you're releasing the drug intraocularly. More than 90% of most drugs are lost in the process of trying to get into the eye. So if you are actually in the eye, if you directly deliver the drug into the eye and let it slowly deliver itself there over time, then you are spared the problem of compliance, you're spared the problem of allergy and surface problems and toxicity, etc., because the drug is acting only where you want it to. The side effects, unless they are actual ocular side effects, are just not there. And we are all going to have to adjust to major new paradigms in treatment once these are available. So change is in the near future. But for now, we still need to follow our basics, define target intraocular pressure based on presenting features. We need to achieve the target intraocular pressure by medical laser or surgery. Uh, we need to monitor for progression. We need to check on the compliance. We need to monitor for side effects. And importantly, we need to tailor the treatment to suit the patient. So thank you.
Thank you very much indeed, Dr. Braganza. Quite an extensive topic covered in very good time indeed. Thank you. I will invite Dr. Harsh and Dr. Pradeep Vyas for their comments first.
Thank you, Andrew. I think it was, I was really impressed by the way you brought in a completely new conceptualization. I think rightly so, the PGs keep hearing same and same lecture about medical treatment and all those hundreds of slides that they see. And but you really put everything in such a beautiful perspective, in a way that it was really indeed a pleasure to listen to you conceptualize the target pressure. That was really, I've actually never heard it, and it gave me such an insight. Really, that was wonderful. So I think the medical management, there are millions of questions and millions of answers, and I bet the students will ask. I just wanted to check with you. Would you be if you do a diurnal variation, would you also be would like to do a flattening of the variation curve, or would you just like to achieve a target pressure?
I still do diurnal variations because I'm lucky enough to be in a medical college where we have postgraduate students who are on duty, and this would be just one little additional thing for them to do. So we do have that facility available to us. And I have found it useful, mainly when we find that the fluctuation is actually going beyond what we have defined as the target pressure. So if I've decided that, my target pressure for this patient is 18, and I'm constantly getting 15 or 16 in the OPD, and I still find that I'm not very happy with the way his fields are going, if we do a diurnal variation and find that the pressure is fluctuating from, say, 14 to 21, then obviously it is fluctuating beyond the range that we have allowed for the target pressure. And possibly this is the reason why the treatment is failing. So this is a very classic case of a diurnal being used usefully in treatment. I'm not aware of any medical way of actually flattening a diurnal curve. If we find that the patient's already on maximally tolerated medical treatment, and I left out that concept because, this is something that raises a lot of arguments. So I left that out from the talk, but we can discuss it. If the patient is already on the maximum medical treatment that they can tolerate,
nothing much
then you would opt for a surgery to flatten the diurnal curve, because surgery definitely does flatten the diurnal curve.
And as a concept for the target pressure, what I have realized is that putting percentages that, okay, we'll reduce it 30%, 20% is sometime in practical life is extremely difficult, because the patients, when they come, we really do not know, because they have so much fluctuating pressure, and many of them are already on some kind of treatment. So to be able to gauge what was the highest pressure and I'll get it down below to this, would you go to those terminologies, or would you say that I'll set my target pressure more depending upon what is the existing damage and where I would keep it?
Yeah, I think that, a few solid pieces of information and evidence that we have, which I mentioned, that if you have an untreated initial pressure, and the untreated initial pressure, reducing it 35% or more probably puts the patient within the safe range. That's one fairly solid piece of information which works across the spectrum. Another, where if you want to look at absolute reduction of pressure in established primary open angle glaucoma, not NTG, but primary open angle glaucoma, which has pressures in the 20s, 30s, or 40s. If you can keep the pressure below 18, you have very likely rendered that patient safe. So that's basically a working rule of thumb.
Yeah.
So
thank you for that, and that was really wonderful. And Pradeep, please go ahead. Pradeep, can we have your comments, please?
Yeah. Hear me? Can you hear me?
yes.
Hey. Yeah. Beautiful talk. So Dr. Harsh has covered most of the things, asking you. Well, my connection is stable. Can you hear me? Am I audible?
Well, you're breaking up in between, so I'm not able to actually follow what you're saying.
Am I audible?
You're audible, but you're breaking up.
Okay. Okay. So my internet connection is not supporting me well. But you tell me two things, what about the unilateral trial? Do you do unilateral trial for every patient of yours?
Sorry, if you turn off your video and have only the audio.
I think so, yeah.
Yeah, that may work.
Yeah.
Yeah, okay. Could you repeat the question now?
Yeah. Tell me about the unilateral trial. Do you do unilateral trial for every patient of yours?
Unilateral dry eye.
The unilateral trial, do you do for every patient of yours?
Trial. Well, I don't routinely do a unilateral trial. When we were using beta blockers, where there is almost 30% of patients are actually not responsive to beta blockers, then we used to routinely do a therapeutic trial for all patients. Now, when we use prostaglandins as the first line of management, there's maybe at the most about 10% of patients who are not responsive to prostaglandins. So a unilateral therapeutic trial is not routinely done at our center. We start the patient on the medications, and if we find that they are not achieving the kind of pressures that we want, then we may say, okay, fine, we now need to formally do a therapeutic trial and establish whether you are responsive to this medication or not. So not as a routine, but only in the case where we find some difficulty and we need to sort it out.
Anything else, Dr. Pradeep?
Okay, so regarding neuroprotection, earlier there was a big hype of, can you hear me?
Yes, we can hear you.
Yeah, so regarding the neuroprotection, Dr. Braganza, initially there was a big hype about the Nimentin, and you have cleared everything. And now the people are talking of citicoline. So, and you mentioned that it's an exciting drug. So,
well, there have been.
Pradeep, can you type it out, because I think the voice is really bad. Can you type out your question or whatever?
I'm so sorry. Citicoline, the role of citicoline.
His question is very simple. What is the role of citicoline these days?
I was asking about the role of the citicoline.
Yeah.
Okay. Citicoline has been tried, and there is some evidence that it may work in neuroprotection, and that too, mechanism not absolutely clear. It probably works by multiple mechanisms, just like brimonidine. Brimonidine works by multiple mechanisms in neuroprotection, but it definitely works. I mean, the evidence that patients with adequate levels of brimonidine in the vitreous, regardless of intraocular pressure control, do not experience the same kind of progression as patients who do not have that same concentration is incontrovertible. But getting that brimonidine at that concentration into the area where it has to act is the problem. And that's why I mentioned drug delivery systems also, because this may overcome those kind of problems. Citicoline, I'm not very sure of. There have been a few trials, and there is some evidence that it may work. But again, how you deliver it and what role it has, not clear.
Okay, we have lots of questions actually, some relevant, some not relevant, and some which have been answered in different lectures. But I would just like to start by saying that I'm really intrigued. You said that you guys have done a study and you found that actually there has not been any change in diagnosis from NTG to POAG per se. My impression sometimes is that, I have diagnosed patients as NTG and, have started treatment for, various indications. And then later on, they have actually come back with higher pressures. So from that point of view, I don't know whether you had the opportunity to attend Professor Weinreb's GSI webinar called Crescendo, where he actually was talking about the personalizing glaucoma with 24-hour IOP. And he was talking about a device that is implantable and which is being studied to obtain 24-hour IOP, quite apart from the trigger fish contact lens system. And he very categorically stated that he thinks that NTG and POAG are actually a blur, the division between the two. They are not distinct entities. This is what I have understood from his talk. And that, it merges into POAG, with time or with greater observation.
There's definitely a school of thought which says that NTG and POAG are a spectrum. But I'd like to go back about, maybe 8 or 10 years ago when there was a very strong effort to actually subcategorize NTG into pressure-dependent and pressure-independent NTG. We no longer use that classification. But to my mind, that was a very important classification because definitely there were patients whose pressures were 10, 11, 12, with NTG. And there were patients who were 18, 19 pressure with NTG. And they were like a different set of patients. However, if we just follow the established definitions, when we diagnose NTG, we diagnose it based on at least an office DVT. So we have checked several pressures, may not be a full DVT. And we have then decided, okay, this is NTG. And we follow the established treatment protocol, which is don't treat unless you see some kind of progression. Okay.
Absolutely.
So when we did this study, and this was a thesis actually, which was carried out over 1.5 years, we washed out a lot of primary open-angle glaucomas. We washed out a lot of NTGs also on treatment and did diurnal variations on all of them. And we did not find, and with complete statistical validity. And we did not find a single patient in whom we had to redefine the diagnosis.
And how many patients
I myself was surprised.
How many patients, Andrew?
100 and something. I can't remember the exact numbers.
So actually, we cannot take you really can't put it as gospel truth over there, that.
Correct. That's right.
So but that's a thought. So let's not put it into the PG's mind, because as of now, established whatever is there, I think we should leave it at that, especially for postgraduates. I think we can leave it at that.
I think that's fair enough. So, yes. And, we also studied, in this same set of patients, we also studied supine nocturnal IOP in NTG and in POAG. And although we found that quite often the supine nocturnal IOP was above the target pressure, we were not able to establish any patient who had actually progressed by having this pressure above the target pressure. So
perhaps 1.5 years is not long enough in their life. I don't
possibly.
know.
No, quite possibly. But I'm just giving you the sort of concept that we try to look at.
So, Vanita, go ahead with the other questions.
Yeah. So there's a question here which says, when do you prefer an SLT? When do you do an SLT, and is it preferred over medical therapy?
Well,
It's not totally related to your talk, but do you mind taking
okay.
it?
No, that's fine. No, as far as I'm concerned, SLT is not preferred over medical therapy. If we have to follow the traditional hierarchy, you give medical therapy until you've reached the limits of what medical therapy can achieve, and then you try laser therapy. Laser SLT is again not established in Indian eyes, although there is a strong move towards that, and there is definitely evidence to say that it does work. I have used SLT outside India in non-Indian, in Caucasian eyes, and it does work there. I've not used SLT in India on Indian eyes, so I have no direct experience. But my colleagues who have used it say that it does work, but they are not very sure about what role it has, where it fits into our therapeutic armamentarium. However, I would have no hesitation in saying that it is not preferred over medical therapy.
Would it be fair to say that a SLT has a sort of a definite lifespan? You can do it as an intervening procedure if you are waiting for surgery, or patient not fit for surgery, or whatever.
Sure. I mean, the
maybe
evidence,
pregnant ladies who want to tide over the period.
Yeah, I mean, this is not directly related to this topic, but the evidence does seem to show that SLT does work briefly, like all laser treatments. It works for some time, and then it, the IOP again escapes control. So you can say that it could be used as a temporizing measure, except that we have no way of defining in whom it's going to work and whom it's not going to work. So that's the situation we are in right now.
A number of studies on that, and in our this thing, and it worked in 60% of our patients. Indian eyes, it works less than it works in patients outside, and that is why they are using as their primary method.
Yeah, but like Dr. Braganza, even I have used it mostly in Caucasian eyes. I've not had the opportunity to do it in our eyes. Our kind of South Asian eyes, and even then in Caucasian eyes, I felt that there was a period where it responded, and it escaped response after that period.
That is well established.
Yeah.
So let's move on, Vanita. I think let's take
okay. And again, we are obsessed with steroids here. Which steroid causes maximum rise in IOP?
The ones which cause maximum rise are actually banned. It's the, I can't remember the name. It was marketed briefly as a steroid to use in children, a very long-acting, highly potent steroid. But that caused almost 40% of patients' rise in pressure. And children were particularly vulnerable. So that steroid is no longer commercially available as an eye drop preparation anywhere in the world. Obviously, the more potent steroids also have a more potent effect on intraocular pressure. The steroids which penetrate more into the eye will definitely have more of an effect on intraocular pressure, which means it is prednisolone, dexamethasone, betamethasone are approximately equal. Fluoromethalone, loteprednol, things like that are less. But all steroids have the potential to raise intraocular pressure.
Yeah. Difluprednate is available nowadays.
Difluprednate.
Yeah. So would you rate that higher than
Difluprednate? Yes, definitely.
Yeah. Okay. And can PGA analogs increase IOP is one of the questions. And what could be the mechanism?
Not that I'm aware of.
They may be non-responders, but...
Yes. Increase IOP? No, I don't.
Okay. Right. And how would you define maximum medical treatment? Is it 4 drugs, 3 drugs, or?
Okay, it's not defined in this. I deliberately left out because it's something that's very controversial definition. Okay, it's not defined in the number of drugs. Actually, it would be defined as the minimum number of drugs used to achieve the maximum possible reduction in intraocular pressure in an individual eye.
Right.
So suppose I use 3 drugs and I achieve a drop, let's put it in percentages, okay? Say I achieve a drop of 35%, okay? And I get the same drop of 35% if I use only 2 of those drugs. Then the maximal medical therapy for that patient would be the 2 drugs and not the 3. So it's important that you realize maximal medical therapy is actually the minimum amount of drugs required to achieve the maximum possible effect for a particular eye. That's the concept.
Yeah, I suppose that's why the recent terminology of MRT, maximum reasonable therapy.
Maximum reasonable therapy, maximum tolerated therapy, because then you also have to take into account whether the patient is going to be compliant, is going to tolerate the side effects or the stinging or whatever it is, all that. So,
right. Again, this is a question which is actually not, and we do have a few minutes left, so if you don't mind answering.
Sure.
Should we give steroids in acute angle closure? And I you know,
well, it depends on how you're going to go on with your management. I have no objection to steroids in acute angle closure because quite often you have a fair amount of inflammation. We certainly use it for other acute glaucomas like lens-induced glaucomas because those are all associated with a significant amount of inflammation. So there's no problem in giving steroids to control inflammation in acute glaucomas, including acute angle closure glaucoma. It's important, though, to treat the intraocular pressure. The question is not the steroids. The question is the intraocular pressure, and you bring that down as fast as possible.
Yeah.
And you will need to use steroids when you're doing the PI anyway. So.
Yeah, there is a little obsession with, steroids and not giving it and all that. And there is another question which I think we should not be answering here today because it has been answered before, and that is explain steroid responders.
I think
we had a whole lecture on it. Yeah, we had a whole lecture on it. I'm sorry, we'll not take that.
You can go back into the YouTube and check that.
Yeah, definitely. Absolutely. They can do that. So thank you so much, Dr. Braganza. We are really grateful that you could give us so much time. And
thank you for the opportunity.
And a new perspective.
A wonderful talk. And we hope to see you sometime in person. Thank you very much.
Okay. Thank you and good night.
Thank you.
Right. I think we leave the case today, although I did have one prepared on DVT. So, I normally interact with the hot seaters at this point and, you don't have to stay. But I was just wondering, Sunil ji, time hai, nahi hai?
Yes, ma'am. Please.
Hai?
Yes, ma'am.
Kara ke rahenge aap? Okay, okay, thank you. Right, so I will just briefly present this case. I will ask you guys to describe the disc though, because I think you need to get into the habit. Many of the hot seaters have actually left. Anyway, here we are. Let's share the screen. Just a minute. Yeah. Okay, so here we have this case of a 50-year-old male. He, is a hotshot executive, lives in Hyderabad or lived in Hyderabad. I don't know about now. And he was referred with a diagnosis of glaucoma in both eyes with IOP of 22.6 and 22.4. Now, obviously, the methodology was not mentioned with this kind of percentage point since we don't have digital applanation in our country used widely. I'm assuming this was a Shayad stenometry. Okay, anterior segment examination was absolutely fine. I couldn't find anything there. When we measured intraocular pressure, it was 18 in both eyes, angles were open, and post dilatation, it went up a few points, but that really doesn't matter. Now, I don't have his disc at presentation, but this was my drawing. I have discussed drawings with you in details. Remember, every time you look at a disc and if you draw, you pick up features, qualitative features, much better. So if you remember, I told you I always measure the disc and I like to use the 66 diopter because it gives me the actual value. So if you can see, the right disc is slightly smaller than the left, although both are average in size. The writing in blue is that of my fellow, and the writing in black is me overwriting over it. I have called it a 0.75 disc CD ratio, but most importantly, what I agreed with, that both eyes RNFL was fine and that the rims were healthy, even though on the left side, inferior was slightly less than superior. But I agreed with the fact that it looked physiological. So at this stage, a visual field, is mandatory if you're being referred for glaucoma, minimum visual field. Clinically, I did not think there was any need for an OCT at that time, and was not that widely available. Nonetheless, a CCT was 602, 601 with a pressure of 18 and a swap. I decided to do a short wavelength automated perimetry, which, as you know, is blue on yellow, and it's good to do it in eyes which don't have cataracts, but it always has its limitations. So diagnosis was probably ocular hypertension, and referred back to the doctor who sent. So this doctor then re-referred this patient 2 years later. Again, no definite family history of glaucoma. CCT was the same. And when we recorded the IOP, this time it was on Goldman, was 24 and 21. Angles were open. So this is what the disc looked like. And I want someone to answer. I don't think there are very many people around. Dr. Veer, would you like to take that? Are you around?
Ma'am, am I audible?
I've already told you this is an average size disc. I can also give you the other one for comparison. And I've told you that the left one is slightly larger than the right one.
Yes, ma'am.
Yeah. So what are you seeing? Qualitative features. When I say qualitative features, I mean size, which yes, I've already given you. Neuroretinal rim, yes.
Ma'am, in right eye, it seems much reduced in the inferior quadrant, ma'am.
You feel it is reduced?
Yes, ma'am.
Okay, very good.
In the inferior.
Compared to superior, excellent, yes.
And also temporal, ma'am.
Temporal, we're not that worried, aren't we?
Yeah.
What is it we said? We agreed that isn't may not be valid in all discs, but temporal is always the thinnest.
Yes.
If temporal is the thickest, remember that disc is likely glaucomatous. Likely. You still have to prove it.
Yes.
Okay. So look at the RNFL now.
Ma'am, inferiorly, there seems to be an RNFL defect, ma'am. Then
what kind?
There is more prominent and the obscuration of.
So there is actually diffuse loss. Very good, actually, if you've picked that up. Can you see there is more striation superiorly, even though you have these slits? Can you see the slits?
Yes.
Coming right up to the disc. If it's coming right up to the disc, it is significant. Remember that. Okay. What about the left one?
Ma'am, even in left, the qualitatively, I can feel there is thinning of the neuroretinal rim in this inferior, ma'am.
Very good. Yes. One thing we missed out on, there is peripapillary atrophy, isn't it?
Yes, ma'am. That is both eyes.
Yeah. Good. Very good. And what about the RNFL?
Ma'am, inferiorly again we can see it's an defect, ma'am, RNFL defect in the inferior.
Yeah, there is diffuse loss compared to superior. Look at the pattern superiorly, but very little pattern inferiorly. And, there are some slits, but these don't seem to come up to the disc just yet. All right. So look at the red free. The RNFL becomes so clear. Both inferior ones are diffusely lost. Superiorly, definitely there are a couple of slits on the right side, maybe suspicious slits on the left side. Okay, agreed?
Yes, ma'am.
Very good. Okay, so sorry, I don't need to show this to you anymore. This is what I had drawn once before I took these photographs. This is what I wrote, that I see two slits there. On the right side, I see a slit on the left side, and I say query diffuse loss inferiorly. What got cut off is both eyes. Okay, so definitely this patient, sorry, the slide got repeated. Yes. So this is the visual field now. No more swap. I did a standard automated perimetry, SAP. Okay, white on white. The right one looked okay, and the left one started showing a paracentral defect. Can you see? Is this meeting your Anderson's criteria? Quickly.
Less than 5%, 3 quantities there.
Absolutely, it is. Okay. So what do you need after that is actually a 10-2 because you have got a point threatening fixation. Look at the OCT and more importantly, look at the GCC significance. I don't know whether GCC significance has been talked about in details, but at one of these interactions, I will tell you about it. Okay. So what all these red areas mean is that there is diffuse loss of your nerve fiber layer in the right eye, both superiorly, inferiorly, left eye, mostly inferiorly. Okay. So now your diagnosis obviously has to change. What would your diagnosis be?
An open angle glaucoma we can now label.
Yeah. Right one is pre-perimetric, left one is now full-blown POAG. POAG. You don't call it full-blown. You call it POAG, and in the right one, you'll call it pre-perimetric. So, yeah, I wanted to see, and because at that time I had the facility, I don't have it anymore, I have to say, and I do miss it, a 24-hour DVT, just to see why the patient, within 2 years developed so much change on the pressures that the patient presented with, as well as the CCT. Remember, the CCT is rather thick.
Yes, ma'am.
Okay? So a pressure of 24, 21 may not be significant at all for a patient who's got a pressure of 24, 21. So here we are. What did we find? We found the early morning IOP is really high. Okay? Which you wouldn't normally get at your OPD consultations. Okay? So was at 2 a.m., 5 a.m. and 8 a.m. So a prostaglandin analog was started. Why? Because it works 24 hours, works well. Okay. Then what happened? Visual field was done. 10-2 we're going to show you now. 10-2, as you can see, has a fair amount of scotoma close to fixation. However, this gentleman, his pressure kept rising, and over the next 4 months, he was on 4 drugs. And although here we are talking maximally tolerated, yeah, he tolerated all 4. But what happened was he, on 4 drugs, his DVT was repeated and he was still fluctuating quite a bit. And not only was he fluctuating, this on treatment, you should not be fluctuating so much, right? So surgical options were discussed at this stage because also remember I told you he's a busy executive. He cannot continue so many drugs. So he had trabeculectomies, the right and the left eye. And since then, his pressure has been very, very much controlled. And his visual field too has not progressed from where he was. So DVT does help in controlling, in picking up the peak IOP. And not just that, if you're progressing, then it helps you to find the fluctuation that might be happening. So that is where the indication of DVT is. Now, I had promised a couple of weeks ago, I think, what is the recommended signal strength on OCT. I showed a Triton, which is a swept source Topcon OCT. The signal strength should be about 50. The Spectralis, or the Heidelberg one, should be more than 15, the range being 0 to 40. The OptoView should be more than 40, and the Cirrus Zeiss should be more than 8. This you should take a screenshot and keep. Right? That in a nutshell, quickly was, how the DVT can affect management in a patient. Okay?
Yes.
So I think we'll call it a day here today. The next talk on Friday again is on medical management, the second part, where although it says only 2 drugs will be discussed in detail, it might be more. Prostaglandin analogs as well as alpha adrenergics. Okay?
Yes.
Right, guys. Good night.
Ma'am, thank you for
Thanks
the
for listening. Yes. Take care.
Good night, ma'am.